Welcome all to the session of AVD on canine atopic dermatitis. I welcome Dr. Thierry Olivry and request Dr. Nagarajan to deliver the welcome address, please. Thank you.
Good evening to everybody. Being the president of Association for Veterinary Dermatology India, it's my pleasure to welcome all the vets for the significant, memorable webinar. Association for the Veterinary Dermatology India was registered on 6th December 2019 to create interest and awareness in dermatology among veterinarians, which covers majority of our practice. To identify the causes for various veterinary dermatological problems in India and to solve them in successful ways. To document or publish the studies after conducting research in collaboration with the universities and industries. To improve the standards of veterinary dermatology practice in India by providing continuous knowledge through webinars, seminars, symposium, conference, hands-on workshops, and updating the latest findings. And to finally, to create Indian veterinary dermatology diplomats. In this regard, we have initiated a dermatology webinar series, which is ongoing in a successful way. Indeed, it is a moment of great pleasure to reveal that we keep updating through lectures and scientific publications in veterinary dermatology. In this juncture, today we have the world-renowned legendary speaker, Professor Dr. Thierry Olivry, among us to promote the webinar towards the path of success. On behalf of the Association for Veterinary Dermatology India and Indian vets, I take pride in welcoming you, sir. We also pay our gratitude for accepting and honoring our invitation. Also, I sincerely thank the Virbac team for helping to make this session happening in a successful manner. Now it's time to call upon Ms. Vanessa from Virbac to deliver the short note about our guest speaker. Thank you.
Thank you very much, Dr. Nagarajan. It is indeed my privilege to introduce Dr. Olivry. Dr. Olivry graduated from the Veterinary School in Toulouse in 1984. In 1991, he then moved to the US for a residency in dermatology and a PhD in comparative pathology at the University of California, Davis. He is both certified by both European and American colleges of veterinary dermatology. From 1994 to 2019, which is a significant 25-year-long contribution, he was a clinician scientist in dermatoimmunology at the North Carolina State University College of Veterinary Medicine. With his immense contribution to the field of immunodermatology from 2001 to 2004, he was the chair of the International Task Force on Canine Atopic Dermatitis. From 2008 to 2009, he was the president of the European College of Veterinary Dermatology. He has rightfully earned several awards and recognitions. To name a few, in 2004, he was awarded the American College of Veterinary Dermatology Award for Excellence for Outstanding Contributions to Science and Education. In 2005, the North Carolina State University Clinician of the Year Award. In 2010, the Pfizer Award for Research Excellence at North Carolina State University. In 2013, the World Small Animal Veterinary Association Hills Excellence in Veterinary Healthcare Award. And in 2020, the European College of Veterinary Dermatology Lifetime Career Award. He's also the honorary member of both Latin American and European Societies of Veterinary Dermatology. Very appropriately, the dermatology unit of the Aristotle University of Thessaloniki in Greece was named after him in 2003. He has authored more than 270 peer-reviewed articles. His core research area is focused around mechanism and treatment of atopic dermatitis and itch in dogs, and he has characterized multiple new autoimmune skin diseases in both small and large animal species. More recently, he expanded his interest onto food allergies, including food allergen characterization and cross-reactivity. Dr. Olivry now shares his time between being a part-time research professor at the North Carolina State University and consulting for animal health and human pharmaceutical and biotech companies. With that, Dr. Olivry, it's a pleasure to have you with us, and the stage is all yours.
Thank you very much for your kind introduction, and thank you very much to Dr. Nagarajan and the Association for Veterinary Dermatology for having invited me to talk to you about the disease that has been my passion for more than 25 years. And first of all, congratulations for establishing that association. I think it's a significant step in promoting our specialty to your fellows. And I wish you much luck and the possibility to hold in-person seminars as soon as this pandemic is over. So let me first share my screen and get it started. Okay, can you see it?
Yes, Dr. Olivry, it's visible.
Yes, sir.
Okay, so during this session, we will have two parts. The first part about the diagnosis of atopic dermatitis in the dog. Then we'll have a short time for questions and answers. And then the second part will be the general principles of therapy following the international guidelines. So as Dr. Pereira was saying before, I had the luck of and the pride of chairing the AVD task force on canine atopic dermatitis already 20 years ago. And this was a work of about 2 years. And the most difficult part at the end of these 2 years was to agree on a set of definitions, of which I'm going to share a few of them. So let's define first atopy. Atopy or atopic state. This is the genetic predisposition to develop allergies that are due to IgE. So there are cases where that may not be genetic. We may not use the word atopy for that, but we are looking at the general predisposition. And then consequently, the atopic diseases will be any type of manifestation of atopy. In people, you will have allergic rhinitis, asthma, atopic dermatitis, etc. In the dog, it's predominantly, I would say, atopic dermatitis, rhinoconjunctivitis, and perhaps in rare patients, asthma. We had a definition of atopic dermatitis in 2001, but as in 2005, there was an update and a change in the consensus definition in people, we decided already 5 years later to immediately mirror the definition that had been given in people. In these words here, you have all of what you need to know about this disease, and in blue are the most important words. First of all, it's genetic, and I will comment on this in a few minutes. It is an inflammatory and itchy allergic skin disease, meaning that if you don't have itch at all, it will be very hard to consider that your dog has atopic dermatitis. Finally, a couple of words, characteristic clinical features. This is probably the most important part of that definition, because as I will show you in the following slides, there is a unique distribution that will allow you to make this diagnosis. Finally, associated with IgE antibodies against environmental allergen, this is what will make the link to atopy and also will differentiate from a disease that we have named so far atopic-like dermatitis, which is atopic dermatitis in which you cannot document any IgE-mediated allergen-specific relationship. So that was in 2006. Where are we in 2020? We are still not sure what atopic plaque dermatitis is and whether or not it really exists. Because the study was published a couple of years ago that looked at patients with atopic dermatitis and patients with atopic plaque dermatitis, and they are indistinguishable clinically. And so I am not sure that we should pay much attention to this atopic plaque dermatitis. So how common that is? I was trying to find data about the prevalence in India, but could not. But I've assembled here what I could find in the literature. So these would be the percentage of dogs that would have atopic dermatitis when presented to general practitioners. So this includes every dog that comes to your practice for vaccination, healthy or sick, young or old. And you can see that it ranges about tenfold from the study in 1995, 0.5% in Sweden, to 2001, about 5% in Scotland. But what is very interesting here is the publication, the data that was done in a very large corporate practice network, the Banfield network, that showed that there was a 30% increase over the preceding 10 years. And this is actually to put similar data were presented already in Sweden, that between 1995 and 2002, there was an increase in prevalence. So this is exactly the case as in people. Over the years, especially over the last 2 decades, there has been an increase in the prevalence, perhaps because of an increase in hygiene, a decrease in parasites. We're still not sure. We do not have much data in the dog yet. If we look at the pet insurance claims, you can see that 2 different insurances have actually several, we have now 1, 2, 3, 4 different insurance companies have reported that it is either the first or the second claim for which they pay damages or they reimburse the clients. So you can see that it is a very worthwhile study subject, as it will represent quite a few of your patients. If we look now at the dogs that are presenting to the veterinarian for itch, specifically chronic itch, probably itch that is greater than 1 month in duration, you can see that by far in this very large international study of 1,000 itchy patients, that atopic dermatitis is at least 10 times much more prevalent than the second disease, flea allergy dermatitis. So 20 years ago, it would have been the opposite, because 20 years, 25 years ago, we didn't have the new flea control products that are now so available all over the countries. And flea allergy dermatitis was much more common. But now that every dog, at least in intermediate and developed countries, are being treated with anti-flea medications, then the prevalence of flea allergy dermatitis has decreased. So now let's look at the signalement, or what are these patients? What do they look like? Where do they come from? Well, first of all, let's look at the male to female ratio. It's a 1.0, meaning that males and females are equally represented. But based on this particular study that is referenced below, I am putting actually 2 brackets with different breeds. Let me explain. This was a study of breed variations of atopic dermatitis in the dog. And here is a very important concept to start with. It's not a disease, it is a syndrome. Atopic dermatitis is strongly associated with genetics. But that doesn't mean that every breed will have the same mutation. What that means is multiple different mutations, and this is the case in people, will result in similar clinical signs. But there will be variations between breed, from breed to breed. Let's start again. Our male to female ratio. Boxers, it's lower, meaning that there are more females that are affected significantly than males. In retrievers, It's the opposite, 2.5 times more males than females. What does this mean? We don't know yet. Age of onset. This is where it is very interesting. Because if you take any textbook, you will read that atopic dermatitis will start between 6 months and 3 years of age. Is that the case? Well, not always. If we look at the average age of onset across these 840 dogs, it's about 2 years of age, but with some variations. The French bulldogs start younger. The German Shepherd dogs, GSDs, start later. But what about these dogs? We say 6 months to 3 years of age, but 10% of the dogs will start before 6 months of age. In particular, the Dalmatians. Actually, not the Dalmatians, but look at this. 40% of the Shar-Peis will start younger than 6 months of age. And conversely, some dogs, like retrievers, may develop the disease much later than 5 years of age, something that initially would have said is not really compatible with the disease. So look at all of this information I'm giving you. It's as a general trend, but there will be some variation from breed to breed, and there may be some unique variations in your country, or I should say your continent, because there may be unique variations in the genetic predisposition and the gene mutations in dogs in your country. Here is a factor that shows this genetic predisposition. This was a pair, a son and mother, Westies, that I saw when I started my residency at UC Davis. Already, that was in the early 1990s. By the time I moved to the US, I had heard of these Westies with severe atopic dermatitis. By that time in France, where I was practicing in Paris, there was not any. And it was quite a surprise to see how severe these dogs were when I moved to the US. By 1992, 1993, some champions from the US were moved to Europe and they transmitted the trait. And by now, Westies, or at least in the 90s and the 20s, Westies were the most commonly affected breed in Europe. And now they are being replaced by French bulldogs. So this illustrates that this geographic predisposition, this genetic predisposition will vary depending on time and depending also on the geographic location. So I tried for several years with a group of colleagues to find the mutations in Westies, focusing at one breed in the US. And here are, for example, 3 different families, and you can see in black and gray the dogs that were affected. You can see how complex and how inbred these pedigrees are. What we could find is that this is a genetic predisposition with an autosomal recessive predisposition, but a very strong prevalence and role of the environment. So we continued a couple more studies, and now we have narrowed down the mutation to a region of chromosome 3 in the Westies, but we still do not know which particular mutation is causative of the disease. What will make you think, or should make you think, that this dog has atopic dermatitis? First, a juvenile onset pruritus. If the younger the dog develops pruritus, I would say the more likely he may have the disease. A history of recurrent infections of the skin or ears. Sometimes the association with an other allergic disease, like a dog that has sneezing or rhinorrhea, a dog that has teary eyes or is scratching his eyes, suggesting that he may have an associated rhinoconjunctivitis. Finally, we were used to separate the dogs as having a seasonal disease or non-seasonal signs, but it depends on the geographical locations. When I was practicing in the US, I would say most of my dogs had a non-seasonal clinical signs, plus a worsening of the disease as they were exposed to the pollens, which were very prevalent in North Carolina. So now let's move to the clinical signs. And I will start with the type of lesion that you will see, and then most importantly, the distribution. So looking back into the 80s and the 90s, we were used to say, well, atopic dermatitis does not have any primary lesions. All of the lesions are due to scratching. We now know this is not true. Based on studies of experimental models or spontaneous models of atopic dermatitis, in which we can induce the lesions by exposing the dogs to allergens, we know that the primary lesion is redness or erythema. Sometimes we have what are called micropapillons, very small elevations of the skin, less than 1 millimeter in diameter. They are very, very, very small, not associated with hair follicles. On the right, you have here a dog, which is an English bulldog that was house dust mite allergic. This dog was put in a kennel that was sprayed with a house dust mite extract. Within 30 minutes, look at the lesions that appeared. In the middle, you have redness and swelling of the ear. And within a day, these dogs develop little papules at the site of exposure. Okay, what do we do when we have these dogs that do not have any skin lesions, but that scratch at the site that I will show you later? Initially, I didn't know what to make with these, and I call this atopic itch, because how can we apply the terminology atopic dermatitis if we do not have any skin lesions? I now suspect that the lesions are subclinical, which means that there is inflammation at the site where the dog scratches, but we just do not see it. Most commonly, the redness is very acute, but as the disease becomes more chronic, you are exposed to what are the secondary skin lesions, which are the lesions that occur following scratching, rubbing, biting. For example, excoriations or scratch mark, lichenification and hyperpigmentation or increased thickening of the skin, increased pigmentation in the breeds that tend to pigment. And self-induced alopecia, like here, which is the dog biting and removing its hair. And you will see this as typical locations. So now, if you have one slide to remember, that's this one. Canine and human atopic dermatitis share a common lesion distribution. And this is what makes that particular disease. Here on the left, I've shown you the distribution of lesions in an adult individual, when there is a slightly modified presentation in babies and in young children. But in adult, it will affect the face and the lesions in the folds, in the limbs, behind the knees, elbows, and wrists. Well, in the dog, it's the same. We have the face with some variations. We have also the hairless areas that are rubbing on the flanks and axillae, and the folds, including the digits. Here is another example of a dog with a typical distribution. You can see that on the top left, from the side, not much looks abnormal. But if you turn this dog, you have the areas that are affected in the friction and fold zones. For a long time, I thought, oh, the explanation because of this distribution is because these areas are those with the less hair. And the lack of hair will facilitate the contact with the allergens. Then my friend Dr. Kerstin Bergvall from Sweden told me, well, I have a line of Chinese crested dogs with atopic dermatitis, and the distribution is the same. Look at this. This dog has no hair. yet he has the same areas that are affected. I now think that these areas that are affected are more related to the friction and rubbing which may facilitate the presentation of allergens rather than the lack of hair. So now let's look at a series of pictures to cement in your mind this distribution. I would like also you to pay attention that these are different stages of the disease to show you how different this disease can be. For example, here, a dog with not very active but chronic disease in which there is not much erythema, but you have here hair, alopecia, some alopecia, hyperpigmentation, and lichenification in previously inflamed areas. There is also a common affection of the ocular and periocular area. Excuse me. Here, I am not sure 100% that this is associated with atopic dermatitis itself. But I suspect that this is a cutaneous manifestation of underlying allergic conjunctivitis. Indeed, in one study in which the atopic dogs were seen on the same day by a dermatologist and an ophthalmologist, the ophthalmologist was able to diagnose conjunctivitis in 60% of the dogs with atopic dermatitis. To the left, this is one of these English bulldogs exposed to house dust mite. Within 30 minutes, look at the conjunctivitis. So I believe that this conjunctivitis is what is causing the dogs to rub its eyes and causing this periocular inflammation. Auricular dermatitis, specifically in the inner pinna and the auditory orifice or ear opening. Again, look at this dog, challenged to house dust mites. Before and after, you can see this swelling and redness of the ear pinna. That's characteristic of the disease. The lips, different stages. This is called cheilitis or perilabial dermatitis. Very common in children with atopic dermatitis, very common in the dogs with this disease. Axilla. If you take this particular dog and move the elbow, you will have the exact marking of this area, suggesting that the rubbing and the chronic rubbing is very important. Abdominal dermatitis. Here you could say, oh, I see little papules. This is infected. It's not always infected. You have this is a micropapular rash with very small papules not associated with hair follicles. The perineum is commonly affected on the ventral aspect of the tail and also the perianal area. But here is my favorite lesion. This particular location is the equivalent of the elbow fold in human, which is the typical area affected in this disease. 3 different examples, including on the right, the Chinese crested dogs I mentioned. I absolutely love this location because, in my opinion, there is no other disease that has these lesions at this area. So that makes the flexural lesions of the elbow very specific for atopic dermatitis. And I encourage you to always look at the elbow to see if you see active inflammation or past inflammation. These lesions are usually bilateral. This is the equivalent of the wrist or the ankle in people. This is also one of these flexural dermatitis, and that is very, very commonly exhibiting lesions, especially the ventral metacarpal area. And finally, you have lesions of the digits, between the digits on the top or between the pads. Very common in this disease. Unfortunately, as the disease progresses, the lesions become much more chronic, and then the distribution tends to become less characteristic. And you can see here in these two different wastes how severe the lesions can become. But my most severe picture is this one, a wasty with extremely chronic atopic dermatitis in which the lesions have become more generalized. As an illustration of the breed-to-breed variation, I'm coming back to this paper by Sylvie Willem, published in 2011. And you can see here the relative distribution of the lesions depending upon the breed. So they all have a common theme, but there are some unique variation. For me, the most typical ones are seen in the Labradors and the Bulldogs, but the Sharpeys, the Westies, tend to have a more generalized phenotype. Years ago, my friend Claude Favreau assembled a series of more than 1,000 pruritic dogs, and he looked at criteria that would separate atopic dogs from the dogs with the other disease. And the statistician came up with a series of criteria that would be differentiated or would be present with variable frequencies between atopic dogs and dogs with non-atopic diseases. And it was found that 5 or 6 criteria would be able to differentiate the two diseases. But if you are to use these criteria very strictly, you will still have 1 out of 5 cases that will be misdiagnosed or not diagnosed. So I think the main use of these criteria is maybe as an orientation to the diagnosis or to harmonize the enrollment of patients in clinical trials, but I'm not sure that they would be usable in clinical practice. So now let's look at diseases that resemble atopic dermatitis. Let's look again at this particular silhouette of atopic dermatitis and look at the one of scabies or Sarcoptes infestation. They are very similar. And if I put them together, you can see that it can become quite a challenge to differentiate the two diseases. But there are some very unique differences. Let me point them out to you. Let's look at atopic dermatitis, the face. As I mentioned, the lesions most commonly affect the inner or concave pinna, the lips, and around the eyes with conjunctivitis. In scabies, it's more diffuse or the outside of the ears. Remember, look at atopic dermatitis inside, not outside, scabies outside, typically not inside. Atopic dermatitis has a unique distribution of the friction and flexure areas. Scabies, it's more the extensor areas. Atopic dermatitis is more the medial aspect of the legs. Scabies is more the outside of the leg. Look at the elbow. Atopic dermatitis, the flexure of the elbow. Scabies, the extensor of the elbow. Atopic dermatitis affects the abdomen and flanks. Scabies is typically the sternal area. So again, it is not 100% foolproof, but because scabies is such an easily treatable disease that you don't want to start treating a dog with scabies as if you were an atopic one. So typically, we have for decades separated allergic diseases as food allergy, flea allergy, or atopic dermatitis, meaning environmental allergy. So this was an old concept, and in 2007, we revised that concept to mention that food allergies in some patients can manifest as atopic dermatitis. Food allergy can manifest, as I will show you, in multiple other ways, but in some patients, they are linked. Or in other words, food allergens can trigger flares of atopic dermatitis in dogs that are allergic to these allergens. Let me explain further. If we take the food reactions in the dog, we separate them typically as non-immunologic food intolerances and immunologic food allergies. But if you look at the literature, food allergy can manifest in multiple different ways. Vomiting and diarrhea, itchy, otitis externa, atopic dermatitis, urticaria, anaphylaxis, IBD, and so on. Food allergy is an etiologic diagnosis. It's not a clinical diagnosis. It tells you it's like house mite allergy, drug reaction, bacterial infection. That's not a disease. It's an etiologic diagnosis. You will see, and we have published some papers, that up to 30% of food allergies can manifest as atopic dermatitis, and about 30% of atopic dermatitis have food allergy. Look at this. This is a paper that we published a couple of years ago, looking at the prevalence of food allergy in dogs with different populations of dogs. And you can see that atopic dermatitis, depending upon the series, up to 50% of the dogs have food allergy. In one series, 10%. So this is, in fact, a series of patients that we studied in a few years ago at NC State. These were 83 dogs with non-seasonal atopic dermatitis, in which every dog had skin test, flea control, food elimination diet, and a food challenge. And look at this. In our population, which are here, dogs with non-seasonal atopic dermatitis referred to a university in the US, 52% had food allergy. 46% had positive skin test. 9% had concurrent flea allergy, and you can see how these diseases overlap. So I think that the time where we separate completely food allergy from atopic dermatitis is gone. I am not saying that every dog with food allergy has atopic dermatitis. I'm not saying that every dog with atopic dermatitis has food allergy, but they are very commonly linked. In fact, there are signs that will let you suspect that a dog has a food-induced atopic dermatitis. First of all, because they eat typically the food year-round, the disease has no seasonal exacerbation. Vomiting and diarrhea are common signs of food allergy. So this dog with food-induced atopic dermatitis will have often vomiting and diarrhea. They typically do not have the eyelid lesions, which appear to be more associated with pollens. They less commonly have a pruritus without lesions. They do have lesions. And they appear to have signs that respond less well to glucocorticoid therapy. So now, what about the relationship with infections? It's been recognized for decades that atopic dermatitis is one of the causes of relapsing, recurrent Staphylococcus infections. Different types, exfoliative pyoderma, bacterial folliculitis. Why is this? I'm going to show you the results of a study looking at these next generation microbiome studies, comparing atopic dog, CAD, or controlled normal dogs. Look at different locations and look at this pink. This is the proportion of Staphylococcus in the different areas as opposed to the different genera. That's by sampling the skin, sequencing all of the, amplifying and sequencing all of the bacteria. And you can see that about, let's say, 25 to 50% of the bacteria on the skin of these dogs are Staphylococci. And look at compared to the control sites to the same site in normal dogs. So atopic dogs have a lot of Staphylococci on their skin. And here is the diversity. The more diverse the microbiome, more diverse would mean that there would be representation of the different phyla or genera of bacteria. And you can see here that the atopic dogs have a lower diversity. They have a lower diversity that you can see here because they have many more Staphylococci. And just to show you how the Staphylococci are linked to the disease, an experiment that I had a colony of dogs with atopic dermatitis in which I could reproduce very small lesions by applying house dust mites to their skin. So we measured and amplified the Staphylococci, and in particular, Staphylococcus pseudointermedius. So you can see that, so these are all of these dogs before and with or without challenge. And eventually, I stimulated them with house dust mites. And then at the site, every day and every week for several weeks, we looked at the proliferation of Staphylococci at the site of lesion or away from the lesion. And you can see that as soon as we induce lesions, so the lesions appeared here, and by 7-14 days, you can see that the Staphylococci are proliferating. At the site of lesion, not so much, away from the lesion. And eventually, as the lesions subside, the Staphylococcus goes away. And it's the same with Staphylococcus pseudointermedius. This is all Staphylococci on the top, Staph pseudointermedius on the bottom. So the induction of a lesion, which is maybe 2 square centimeters, leads to the influx of Staphylococci. And as the lesions goes away, sometimes they go away, or they do trigger a regular infection. And we have a study that shows that it's about the same with Malassezia pachydermatis. In particular, in some breeds, Basset hounds, Westies, inflammation induces the proliferation of Malassezia. So, what about testing? Do we need allergy testing to diagnose atopic dermatitis? In the past, we said yes. No, we do not. We think that this test should be reserved only to the rare occasions, I understand that is the case in your country, in which you want to do immunotherapy, which is the desensitization against these allergens, for which you need to know the allergens to which the dog reacts. So, just as a proof that you cannot use these tests to differentiate atopic and normal dogs, I'm looking here at series of studies from the 90s, looking at the prevalence of house dust mite allergy sensitization by skin testing between normal and atopic dogs. And there is no difference. And if you look at the blood samples, it's about the same. Why is this? It's very complicated. I don't want to answer to go into the details, but it's very likely that a lot of the house dust mite allergies represent, in fact, cross-reactivity with Toxocara. But that shows you here that you cannot use blood test or skin test to differentiate and make your diagnosis. So the main goal at this stage of allergy testing is to prepare the dog for immunotherapy. So how would I diagnose atopic dermatitis in 2020? A dog that has the appropriate signalement, a young age, a predisposed breed, a suggestive history, but it's mostly clinical signs that are characteristic. And of course, you have to rule out resembling diseases. And for me, the main diseases to eliminate are infections, and in particular, parasitic infestations, such as scabies. And that will conclude my lecture. I would like to orient you to this particular paper that we published with the ICADA, which is an international committee on allergic diseases of animals. This paper can be downloaded for free, and you have much more details on the diagnosis of atopic dermatitis and the resembling diseases. So this paper can be downloaded for free. So that will conclude my first lecture, and I believe we have time for questions.
Good evening, sir. Thank you. Dr. Vinayak here. So we have a few questions here. Before I go to the questions, let me tell you the first half of your presentation. It was very much liked by veterinarians who are attending it, because I was going through some comments, and they are saying this is very much relevant information as far as today's practice is concerned in India. So thank you so much, sir, for this first part, which was very, very informative to all. Thank you, sir. So we have 4 questions so far. Sir, in your initial part of presentation, you mentioned about atopic dermatitis in one particular case. And the question is, sir, what were the reasons for this incidence where the dog was more than 3 years of age?
I'm not sure what were the lesions in the dogs.
Reason. What could be the reason why atopic dermatitis is developing in a dog which is more than 3 years of age? That particular case, you said it is more than 3 years of age.
I think to answer this question, we will need to understand and have the mutations in this particular breed with late onset. It's exactly the same in people. There are mutations, like for example, mutation in the filaggrin gene that lead to an early onset of atopic dermatitis in people. And there are mutations that there are patients that develop atopic dermatitis in old age. Now, there is even a subset of human patients that have atopic dermatitis for the first time in their 60s or 70s. So we don't know the reason, but there is a reason somewhere. Another possibility could be environmental issues. For example, a particular type of diet might protect, a particular type of environment might protect, or the presence of parasite. You should remember that atopic dermatitis, what is IgE responsible for? IgE was initially evolved to defend against parasites. And if we remove parasites, that may be one of the reasons you may have a lot of allergen-specific IgE and atopy. But it's possible that exposure to parasites might capture a lot of this IgE and cross-reactive IgE, and the parasites might downregulate the immune system to survive. It's been shown. And in that case, you might develop later on. We unfortunately do not have any of this information, but there is a reason. We just don't know it.
Thank you, sir. Thank you for satisfying that curiosity. Another question is about differentiation. The question is how we can differentiate canine atopic dermatitis and bacterial pyoderma and Malassezia dermatitis.
Well, it's a very complicated question, more than it looks, because on one hand, you have Malassezia dermatitis and bacterial pyoderma that are not associated with atopic dermatitis, and you have the atopic dermatitis that is accompanied or predisposes to superficial pyoderma and Malassezia dermatitis. Because Malassezia dermatitis and pyoderma are part of the complications of atopic dermatitis. So the simple answer is you have pyoderma, you have Malassezia dermatitis, treat them. If you have a complete remission of signs, no more itch, everything is perfect, well, you don't have any atopic dermatitis left because everything is controlled. If there is still pruritus left and lesions left, it's an atopic dermatitis with pyoderma and Malassezia dermatitis. And there will be a small subset of patients in which the allergy might be directed to the Malassezia and to the bacteria. But that's probably a minority. So the problem is these diseases can be separated or can coexist. The answer is you see them, treat them.
Thank you, sir. You made it very simple for us. That is your expertise.
You know, I have struggled with this issue for 20 years. It's more complicated. We cannot just say rule out infection because infections are part. Every time you have red skin in an atopic dog, it is loaded with staphylococci. Even if you do cytology, you don't see them. By PCR, they are there, a lot of them. They might already precede the redness because before you get redness, you get inflammation in the skin that changes the surface. Then it's been shown in people, staphylococci come in very early and they dominate. So if you eliminate staphylococci, does that eliminate the disease? No. So this is very complex. It's not just, rule out infections. No, because infections are part of the problem. And the staph themselves can worsen the signs. Very, very complex relationship.
Thank you, sir. Can we move to next question? Now questions are pouring in. We have many questions now. The next question is about seasons. How do they impact on atopic dermatitis? Will the signs are suggestive? We can expect some kind of hint or signal through season or environment, I would say.
Okay, in many of the questions I will answer the same way. It depends. It depends where you live. It depends on the environment, tropical, not tropical. I'm going to give you two examples. I practiced in Paris for years. In Paris, 90% of the dogs have non-seasonal disease. I moved to North Carolina and to California. And in both areas, 3 distinct seasons. Early spring, it's tree pollens. Late spring, early summer, it's grass pollens. And August is the beginning of the weeds till the end of October. So and I will show you some examples in the next lecture. You have dogs that follow the seasons. It just depends to what they're allergic. So to summarize, the season will depend on where you practice and the type of allergens recognized by the dog.
Thank you, sir. I'm moving to next question, where a veterinarian is facing a problem in differentiating contact allergies versus atopy, because history and all, it is sometimes not reliable, and how to differentiate that, contact allergies and atopy.
Excellent questions. Very difficult answer. Let me move to people. It is unclear if atopic dermatitis predisposes to contact allergy in people. There are studies that say that atopic dermatitis makes people more predisposed to get contact allergy, and studies that say no, they do not. What is unique to the dog is that it has a very, very low prevalence of contact allergy, which is an allergy to some plants or chemicals. It is extremely rare in the dog compared to what it should be. They are exposed to the same allergens as in people. There are some plants that cause contact allergy in 90% of the persons exposed. But you can have the dogs running in the forest, covered with allergens, no signs of contact allergy. The owner touches the coat and develops contact allergy. There is something that we don't know. It was studied in the 1980s. You can apply some contact allergen to dog skin. Very rarely will they have skin lesions. So to summarize, there are cases of contact allergy to plants in the dog. Maybe it's common in your area. But in North Carolina, we have a very common plant called poison ivy. Most people are allergic to poison ivy. Dogs are exposed all the time, are not. So to answer your question, how do you differentiate? Well, first of all, assume that 99% of the cases might be atopic dermatitis and only 1% would be contact allergy. And the lesions might be more restricted in contact allergy. The lesions might be more exudative in contact allergy. The lesions might be more seasonal in contact allergy. But keep in mind first that it should be 10 times or 99% times less common than atopic dermatitis.
Thank you, sir. The answer was very much helpful. I am moving to next question. Skin biopsy, would it be helpful in diagnosis of atopic dermatitis?
Only for research purpose. There are some very, very unique lesions. These micropapules, for me, are diagnostic. But for general practice, absolutely no use. No need to biopsy.
Thank you, sir. That was very clear and loud. Thank you.
Clear, and don't waste your money.
Yes. So there is a case described here, Cocker Spaniel, age 7 years, and there is only chronic reddening of ear pinna and itchy eyes. Is it suggestive of canine atopic dermatitis?
It could be. There are some localized forms, yes. It could be.
Thank you, sir.
Not every dog has all the lesions at all sites all the time. What I would suggest your colleague to do is look at the elbows, look at the feet. Is there any hint of mild inflammation?
Thank you, sir. This question looks interesting to me because it is breed-specific question, and you know how atopic dermatitis is distributed in breeds. So the question is atopic dermatitis more commonly seen in pure breeds and less in cross breeds? And what about native breeds susceptibility?
What do you mean native? What do you mean by native breeds?
There are dogs in India. We call them native breeds like Karwani, and there are many other. And sometimes we do not write the breed of dog. We say it is nondescript.
Well, if it's a genetic disease, and keeping in mind that multiple breeds may have multiple mutations, then the likelihood of atopic dermatitis would be higher in purebreds. But if you have unique breeds to India, and suddenly there is a mutation that appears in that breed, you could have more. You could have atopic dermatitis in that native breed. But as most genetic diseases, the prevalence is usually lower in crossbred dogs than purebred dogs.
So purebred dogs are more susceptible. That is what you mean?
Because it's like any genetic disease.
Okay. Thank you, sir. I think we have completed the question and answer time. Do we have some more minutes?
Sure.
Nagarajan sir,
Yes.
can I ask some more questions?
You may.
Yes, sir.
Yeah, one more question.
Okay. So I'll take one last question. Is there a specific antigen tagged in atopic dermatitis diagnosis? If yes, what is the antigen of dust mite antigen that present cross reactivity with atopic dermatitis?
Oh, this is a question we are working on. The house dust mites in people, there are several allergens called DERP1, DERP2 that are the most prevalent. In the dogs, we say, oh, these are completely different allergens. DERF15, DERF18, ZEN1. We think that these high molecular weight allergens, DERF15, 18, ZEN1, are probably not real, but they represent cross-reactivity to Toxocara canis nematode allergens. So we think that the main allergens that have been identified in the dogs are allergens that have occurred when the dogs was exposed to Toxocara canis, and nearly 100% of the dogs are exposed. That may be why most of the normal dogs have also IgE against house dust mites. Dr. Favreau and I work on this issue we think that the real one might be their F2, like in people. But give us a year and we will prove it. Excellent question. A little bit technical, I suppose, for most attendants, but this may change the way we do immunotherapy in the future. Give us a year.
I'll take one more question, sir,
Sure.
because it is asking your opinion on alert spot test. What is your take on alert spot test?
Alert spot test?
Yeah, this might be some spot test to identify allergens. So
it's something that I'm not aware of because I have not seen it in Europe or the US. So I would need more information on this. I cannot answer.
Okay. Thank you, sir. So I think now we will move towards the next part of the session.
Okay, very good.
Yes, yes, we'll move to the next part.
Thank you, sir.
Okay, in this, let me make sure to get my timing right. In this particular part of the lecture, I will focus on the treatment, in particular guidelines that we published in 2010 that were updated in 2015. There is a group of colleagues working currently on a 2020 update, and that will include some of the new drugs that you may have heard about. I will try, I've tried to obtain the information what is available in India or what may come to India, and I will comment on this. First of all, what I'm going to talk about is to treat this particular patient. This is the patient we discussed, and my goal is to provide you with some information on how to treat acute form of the disease or chronic form of the disease. This particular paper is available for free to download. Just go to Google, type treatment of canine atopic dermatitis guidelines, and you will be able to download it if you have not done it so far. In these guidelines, as in the 2010 version, we separated 3 different scenarios. You have a dog that was doing well, and we wanted to treat the lesion acutely, or the treatment of chronic disease and the prevention of disease flares. For each of these situations, we have 2 different patients that are hypothetical. A dog with localized disease and a dog with generalized disease. For example, in this particular one, it's a dog that was doing well, and suddenly it's a season of pollens to which he reacts, and he develops lesions on the axilla and the abdomen. And then you have a dog that has the same type of acute flares, but has lesions that are much more extensive. How do we treat this patient? 3 different situations. First of all, if you can, find out what made the lesions flare. I'll give you an example. If you're allergic to shrimp, and shrimp makes your atopic dermatitis flare, wouldn't it be nice to tell you to not eat shrimp? Then you would not have to treat. Second parameter, improvement of skin and coat. This is where topical medications are important. And then treatment of the disease with medication. These are some of the factors that have been shown to trigger worsening of the disease. And you can see here on the right-hand side, this issue with contact dermatitis, possibly. What questions should you ask your owner? Well, first of all, do you know if in your area the pollen season changed? Has the dog been exposed to foods that are known to create exacerbations. Does the dog have fleas or any other parasites? Does the dog have an infection? Coming back to the questions we had. About pollens, this is when I was practicing in North Carolina. We had the chance to have a government organization that was counting the pollens in the air between February and November. And we had the tree pollens that were going in the spring, followed by the grass pollen in black, and then the wheat pollen in August. And there was one particular weed in the spring. Well, I used this type of graph when I had a dog that was really flaring at a particular day. And this could be an indication for performing immunotherapy in the future. When we see these lesions, the question that you need to ask yourself is, are these lesions caused by yeast or bacteria? So the standard of care is to do cytology. But I'm now very skeptical because by PCR, if I look at this red lesion, I will find staphylococci. So your answer will be, do you have enough evidence to want to treat with antiseptics or anti-infectious agents? Unfortunately, the more anti-infectious agents you use, the more resistance to antibiotics you will get. To be honest, I don't have the answer to these questions because every red lesion in a dog is contaminated colonized by staphylococci and malassezia. So how do you know which one to treat? I will treat if I see pus. I will treat if I see edema. I will treat if I see exudation. Redness, I don't even look with cytology. Improvement of skin hygiene and care. This is where bathing with a non-irritating shampoo is important. And I urge you to monitor if you have an acute flare. Ask the owner, did you bathe your dog? Did you change shampoos? Because in people, it is clear that some particular soaps, especially those with an alkaline pH, will exacerbate lesions of atopic dermatitis. This is why, for decades, human dermatologists were advising their patients to use acidic soaps or acidic non-soaps, acidic lotions. So pay attention to that. At this stage, there is no evidence of superiority of any brand, no evidence of efficacy of any shampoo containing oatmeal, anesthetics, or antihistamines. But here, there is evidence of benefit of two lipid-based shampoos. These are the Alomil from Virbac and the Duxocam for Seva. In the guidelines, in general, we recommended some specific molecules. But when a trial demonstrated the activity of a particular brand, we mentioned the brand. So if you see a brand being mentioned in this slide, it's because there was at least one good randomized controlled trial that showed the efficacy of that particular brand. Otherwise, when we would recommend unique molecules. In the treatment of the acute flares of atopic dermatitis, topical glucocorticoids have a role because they will provide a strong level of medication at the site of inflammation. Obviously, they are better for localized than regional skin lesions. But not every topical steroid is equivalent to another because the strength depends, the efficacy depends on the type. Maybe ointments are superior to gels or lotions. There are different salt of each glucocorticoid and different strengths. What is important is that you use at least a moderately potent steroid at least once a day until the lesions goes away. And the steroid that has been most studied for atopic dermatitis is the cortisone spray. There are several trials that documented clearly its efficacy. Look also at the effect of all glucocorticoids. All glucocorticoids should be used more preferably when you have more regional or generalized disease. If you have very localized disease, you can use localized glucocorticoids, and of course, topical and all glucocorticoids can be used concurrently. This is one of my dogs in which I applied house dust mites to this area. This dog was allergic to house dust mites, and very rapidly we get lesions. If I treat this dog with glucocorticoid, you can see, as you know already, that the lesions will go away. No surprise. I believe you do not have this drug. It's an immunosuppressor called oclacitinib or Apoquel, launched by Zoetis in 2014. It is an inhibitor of unique enzymes that are involved in cytokine signaling. Its efficacy is very fast, and here are the protocols. For the treatment of acute atopic dermatitis, it's uniquely effective without any side effect. For example, in this dog with an acute worsening or atopic blepharoconjunctivitis, you can see that within 2 weeks, the lesions go away. What is unique to oclacitinib is that it works within hours. I will comment on it a little bit later. In the first study that was published for oclacitinib, you can see that within a day or two, you start to have most of the dogs that have more than 50% reduction in itch, plateauing with 2/3 of the dogs. Which medication will not work for atopic dermatitis? Well, most antihistamines are not effective. Why? Because histamine is probably not an important mediator of atopic dermatitis. However, there is one trial that suggests the efficacy of the istacalmine, a combination of 2 antihistamines. There are other drugs that will not work: fatty acids and tacrolimus and cyclosporine. These are drugs that take much longer time to be effective, meaning that if you have an acute flare of the disease, by the time the lesions will worsen markedly before they improve. These drugs should be reserved to the treatment of the chronic disease. So to summarize, the treatment of acute atopic dermatitis involves either steroids or Apoquel. These are the 2 drugs, steroids and JAK inhibitors, that will be effective for the treatment. But what about this chronic atopic dermatitis where the skin is thickened, where the lesions can be either localized or generalized? You have seen these pictures before. The principle of treatment is the same as that we discussed, but the drugs are slightly different. You have seen this slide, so the same principle applies. But as I mentioned to you earlier, there is a coexistence of hypersensitivities in the dog with atopic dermatitis. And I showed you this slide already. Keep in mind that about 1/3 of the dogs with atopic dermatitis, in average, have food allergy. Let's say this dog is allergic to chicken. Every time he eats chicken, he develops atopic lesions. But he eats chicken every day, so the lesions worsen and worsen. What is in this dog's interest? We let him eat chicken, and then we treat him every day with prednisone, or we change the diet, and we don't expose him to chicken. This is critical. Look at this dog, chronic severe atopic dermatitis. Look at what happened if you change the diet. This dog was allergic to chicken. This dog was treated maybe for a week or 2 with prednisone, and after that did not need anything. So it is critical that every dog with at least non-seasonal signs get one restriction provocation trial to assess the effect or the influence of the diet onto his clinical signs. Extremely important. You will not, if this dog is allergic to chicken, like on the left, if he keeps eating chicken, he will not be able to be cured. What about fleas? We know that fleas can create flea allergy dermatitis, but they can also flare lesions of atopic dermatitis. Atopic dermatitis, or the atopic state, will predispose the dog to be sensitized to flea bites. So every dog with fleas, with atopic dermatitis, should be put on a strong flea control product, of which there are many products, I am sure, in your country, and this is not, I do not have the time to discuss this in detail, but every dog with atopic dermatitis should be treated for fleas. We discussed already the influence of infections. It's a complicated subject because infections can complicate atopic dermatitis and resemble atopic dermatitis at the same time. So again, if you have signs suggestive of pyoderma, treat them. If you have signs suggestive of Malassezia dermatitis, treat them. And sometimes, like in this case, treatment of Malassezia infections in this dog resolves the signs. I have seen maybe a handful of patients in which the treatment of Malassezia completely eliminated the signs. You stop the antifungal drug, the signs recur. You re-administer the antifungal drug, the signs disappear. Well, in people, some patients have IgE against Malassezia organism. It's been shown in the dog. So the problem is we cannot test it for these commonly. So if you have signs of Malassezia dermatitis, treat them and see what's left. Are you able to completely cure the disease? Are you able to only partially make the dog better? Here again, improvement of skin hygiene and care could be important, and bathing alone has been shown to help improve the signs. What I told you earlier for the shampoos could apply also here. But it has been shown that when there is chronic atopic dermatitis, the skin barrier, the epidermal surface, is abnormal. It has less lipids, it has less normal proteins, it has more bacteria. How can we help this patient? Well, first of all, control the inflammation. I will talk about it later. Second, you may help improve the skin surface, in particular using omega-6 fatty acids. The omega-6 fatty acids will be incorporated in the skin lipids more than the omega-3 fatty acids. It's believed that the omega-3 fatty acids can have an effect of inflammation, but if the effect is present, it's very weak. This is a study that was in fact sponsored by Virbac several years ago. Let's look at, so these are the lipids in the skin, two different types of lipids, three different classes of lipids in the epidermis of atopic dogs. In white is normal dogs. Let's look at the complex lipids. These are the ceramides. These are lipids that contain omega-6 fatty acids. Look at the level of ceramide in normal dogs. Look at the level of atopic dogs. Look at the fatty acid content in normal dogs. Look at the fatty acid content in atopic dogs. But look at, if you take this atopic dog and you give him the Megaderm, which is a lipid combination from Virbac, which I understand in India is called VitaBest. Look at this. You increase significantly the level of lipids to mirror that of normal dogs. So it takes some time, because here it takes 8 weeks to do that, because it takes some time for the lipids, the lipids to be incorporated into the skin surface. But for me, this is where fatty acid supplementation makes sense. You can give it to help normalize the barrier. What drugs are working for chronic atopic dermatitis? We have discussed the topical steroids, topical tacrolimus works, but let's spend mostly the time on glucocorticoids and cyclosporine because oclacitinib you do not have at this stage. Interferons are available in some countries and I will not speak about them. So topical steroids, again, same slide as before, but I will add intermittent application. Every topical steroid that is potent will reduce the production of collagen by the skin. Even the new class of steroids called diasteroids, that is the way it is. It is their mode of action on inflammation will also decrease their effect on the production of collagen. So if you keep applying a steroid, potent steroid, onto the skin of the abdomen, it will become very, very thin. Even this particular product that theoretically should have been less effective on collagen. But look at this Cortavance. When this in pink is the level of the dermis, rich in collagen, look at the thickness before treatment and 2 weeks later. The thickness has decreased by about 40%. That's okay. That is perfectly okay. That proved that the steroid is effective. The advantage of the Cortavance is that it will not have systemic effect, but the effect on the skin will be present. How do you avoid this skin atrophy? Treat for 2-3 weeks and then apply the steroid only every 2 to 3 days because in between there will be enough collagen production. Do not use it every day for months at the same site. All glucocorticoids, you know, they work very well. Here is a good example. And here are the guidelines. Prefer short-acting steroids rather than long-acting injectable ones. The dose that appears to work is 0.5 milligram per kilogram once or twice daily. And here is something that I think is critical until you have the effect you want. If you do the typical protocol, 0.5 milligram per kilogram twice daily for a week, once daily for a week, every other day for 2 weeks, that will work for some patients. That may be too much for other patients. That may not be enough for the dogs with the chronic lesions like that particular Westies. Reduce the dose when you have too many side effects or when you want to reduce the risk. You can reduce the dose every day or decrease the frequency, or you can use what I call steroid-sparing agents. And this is where fatty acids take place. Let me tell you a study about fatty acids. This was, for me, the best clinical trial fatty acids testing in atopic dogs. These were 57 dogs with atopic dermatitis. As the diets contain a variable amount of fatty acids, all of the dogs were first given the same diet for 8 weeks or 12 weeks. Then that was continued for the duration of the study. The dogs were treated with prednisolone at 0.5 milligram per kilogram once a day. Half of the dogs received Viacutan Plus, a omega-6 fatty acid, omega-6, omega-3 fatty acid combination. Half of the dogs received an inert oil. Every day, the owner adjusted the dose of prednisone based on a specific schedule, depending upon the signs. For example, if the signs were controlled, the dose was reduced. If the signs were the same, the dose was the same. If the signs worsened, the dose was increased. As you can see, so in red are the dogs treated with Viacutan. Within a month, both dogs treated with Accutane or placebo by adjusting the dose every day were able to receive only half of the steroid and still be in remission. But after 40 days, the dogs treated with the Accutane needed less steroids, and by 2 months, which is the time needed for steroids to be incorporated in the barrier, they needed significantly less glucocorticoids. So what that means here is this particular formulation allowed a reduction in the dose of glucocorticoid. So I tried to see if the VitaBest contained, excuse me, the same level of fatty acids, and I could not get this information. They have the same ratio of 5:1 omega-6 to omega-3. And there is no reason to believe that you could not get a similar type of effect, but I would encourage Virbac to study with the same protocol, because this is a way to very easily reduce the amount of steroids and their side effects. So cyclosporine is one of my babies. This is the first dog that we treated in the mid-1990s before Novartis even existed. And this dog, by the time I saw him, was on steroids every day, immunotherapy every day, antibiotic every day, ketoconazole every day, and he looked like this. As I had read some papers showing the efficacy of cyclosporine for human atopic dermatitis, I stopped everything, used cyclosporine. Look at this. For the first time, he was fully controlled. Look at this particular dog. For me, this is the most severe phenotype. He's really sad. In fact, he's probably depressed, because look at what happens after cyclosporine. I promise you, it's the same dog. And look at the effect on the mentation. These dogs with chronic inflammation are depressed. Here are all of the studies testing the efficacy of the atopica cyclosporine. And you can, in all of these trials, we used 5 milligrams per kilogram once a day for 4 weeks. Then we reduced the dose in a specific format. If after 4 weeks there was more than 50% improvement in size, we reduced the dose by 50%. And after 8 weeks, if we had a reduction of signs by 75%, we reduced the dose by 75%. And as you can see, it takes about 6 weeks to get a maximal improvement in skin lesions. And by that time, when we decrease the dose, we maintain the effect. Same thing in itch. It takes quite a bit of time to get an improvement. So this is why this particular drug is not effective for acute atopic lesions. So it's very effective, but it's a slow action. Another message is, if you start reducing the dose, you will limit the efficacy. The improvement that you have may stay, but you may not have the maximum improvement. Look at this particular study. In this study, the dose was not reduced at 4 weeks. Look at the improvement. 80% of the lesions were gone. Because it's a slow action, what you can do, you can use glucocorticoid, or you can use a cortavance, I should say, to use immediately as you start cyclosporine. This would be cyclosporine without steroid, cyclosporine with steroid. You can see that the pruritus is markedly decreased. So, how to use cyclosporine? Let's use the proven bioequivalent to what is called microemulsified cyclosporine. You use 5 milligrams per kilogram once a day until the effect you want, and then you reduce the dose. I would like here to point the issue of bioequivalence. I have seen in many other countries who may not have had the Atopica brand that they used formulations that were made by local pharmacies. They are cheaper, but they may not work. Cyclosporine is not absorbed very well in the dog. You need unique formulations to increase the absorption. This is why I urge you to not waste your client's money and only use the Atopica brand or the proven bioequivalents. One of the bioequivalent is a cyclavance from Virbac. And here you have the administration of cyclavance in red or Atopica in blue. And you can see that the curves are identical. Cyclavance is a proven bioequivalent to the Atopica. And these are the two brands that I recommend you to use as they have a proven absorption in the dog. Do not use compounded cyclosporine, do not use topical cyclosporine, do not use cyclosporine in which the pharmacological studies have not been published. This is very important, as otherwise you may be wasting your client's money. Now, oclacitinib, the Apoquel, I will go very fast because I understand that at this stage you do not have the access to this particular drug, but it works superbly well. It works as fast as prednisolone on pruritus. It's faster than cyclosporine for pruritus, but for the skin lesions, it works as slowly as cyclosporine. This is a proven protocol, and after 14 days, you are to reduce the dose to once daily because of possible side effect of a higher dose in the long term. These are the effect on the itch scores of Apoquel in black, cyclosporine in gray. You can see that on itch with Apoquel, within 1 to 2 weeks, you have minimal itch. But once you decrease the dose, you have a rebound, and then it becomes like that of cyclosporine. And for skin lesions, cyclosporine in gray or Apoquel are equivalent. So the treatment of the chronic disease, you have a choice of 3 drugs: cyclosporine, a steroid, Apoquel, and possibly, if you want, this is for the generalized disease. For the localized disease, I would urge you to add the cortavance. Okay, you have treated this dog. The lesions are gone. How can you prevent them to recur? Well, first of all, if you know to what is allergic to, for example, chicken, keep him away from chicken. And 2 other strategies are effective: proactive topical glucocorticoid therapy and allergen-specific immunotherapy. You've seen this slide. If you know that fleas make these dogs flare, keep him away from fleas. If you know that chicken or beef make him flare, stay away from this. If you know that infections are making him flare, make sure to use strategies to decrease the risk of infections. Let's look at proactive therapy. This is my canine model of atopic dermatitis. Dogs, and this is the same dog, that is allergic to house dust mites. On the left, if I don't give anything and apply house dust mites, I induce lesions. If I use an antihistaminic, like hydroxyzine, nothing happens, the lesions come back. If I use steroids, they don't. This is the principle of proactive topical therapy. And I will highlight this study sponsored by Virbac years ago, because I think it's remarkable. 40 dogs with atopic dermatitis were sprayed with the cortavance once a day everywhere they had lesions until they were controlled. Then after they were controlled, they were separated in 2 groups, either placebo or every Saturday and Sunday, the previously affected areas were sprayed with the cortavance. Then the outcome measures, the measure of efficacy was how long does it take for the dog to have a relapse needing treatment. Look at this. If you treat with topical Cortavance and then you stop, by 30 days in average, up to 60 days, the dogs will have a flare. If you apply the Cortavance twice a week, Saturday, Sunday, you can increase the time to relapse 4 times, average 115 days. Look at this here. This is the percentage of dogs that relapse. This is with placebo. By 63 days, every dog has relapsed. You apply the Cortavance, one dog needed 260 days to relapse. Look at this difference. That's just with steroids twice weekly. So what could you do? Well, you can treat this dog with what I call late reactive therapy. You treat them until their lesions go away. You treat a few more days after they disappear. And then you can apply these topical steroids twice a week. So Virbac chose Saturday, Sunday. I think it's too difficult because some dogs may relapse after 3 or 4 days. I typically chose, for example, Sunday, Wednesday, every 3 days. By that time, you would still have enough production of collagen. There would be no side effect. This is being used in people, in children, on the face. It does not have any side effect. But this is very cheap because you may only need to treat a few areas. And remember, the goal is to keep the dog completely normal. If lesion flares, start with glucocorticoids, more Cortavance every day, and then continue with this. I urge you to try this. It's remarkable. And the second strategy is allergen-specific immunotherapy. Look at these dogs. We treat them, their lesions go away, but they come back. But what if we use immunotherapy? We might keep them there. So what is immunotherapy? It's the injections of increasing quantities of an allergen to which the dog is allergic to increase or to prevent or to delay the symptoms associated with future contact. It's a preventive measure. It doesn't work today. It takes months and months. We published indications, criteria for immunotherapy. You would have to demonstrate that the dog has IgE antibodies against the allergens. You cannot eliminate the contact, for example, chicken. And you can't control this dog with medication, or it's too expensive, or it has side effects. And you have to have the owner who has the money, the time, the culture, the willingness to be able to treat this patient. So this alone, I could give you a lecture on how to do this, but I will leave this. This is really for people with additional training. How do you selection the allergens? Serology, intradermal test. There is no evidence of superiority of immunotherapy performed by intradermal test or serology. So in conclusion, what I hope I showed you here is that there is not a standard treatment of atopic dermatitis. It depends. It depends on the stage. It depends on the type of lesions. It depends on the distribution of the lesions, their generalization. Consider the stage, acute, chronic, localized, regionalized. Consider what's available, what's cost effective, how much money the client has. What do they want? They may not want any steroid. They may not want any immunosuppressor. It's ultimately their choice. And your challenge will be to provide them with a solution that they can follow and that they will follow. But first consider the patient's quality of life. And I would like to reflect on how I started practicing dermatology in the 80s. At that time, we said, well, we are dermatologists. We don't use prednisone. We use immunotherapy. And guess what? It didn't work very well. Every dog that I treated with atopic dermatitis, the client went away with a bottle of prednisone. Because when the lesions flare, there is nothing like prednisone to eliminate the flare immediately. I'm not recommending long-term prednisone, but that may be a choice that is needed. Steroids are still the standard of care of anti-allergic medication of every organ, of every species. But what we have now are options to prevent the long-term use. But if the client cannot afford cyclosporine, cannot afford apoquel, cannot afford immunotherapy, by any means, find the lowest dose of steroids, maybe with fatty acids, maybe with cortisone, to keep in control. Your goal is to treat your patient and keep in control, and now we can. And finally, last slide, you will hear a lot of people saying, okay, buy my product, it works, this works better. My request to you is ask for the data. Take nothing on its look. Ask for the evidence of efficacy. And I would like to commend Virbac as one of the rare companies that has done studies to demonstrate the efficacy of their product. This is why you see some of their products mentioned here. It's not because they are sponsoring this lecture. I've mentioned other one. It's because they have done studies that show the efficacy of their product. And it is your job to ask the same standard of every product that you prescribe. Thank you very much. So now we will take more questions.
Thank you, sir. So we will take more questions. But before going to questions, it is very, very difficult into webinars to get the expression of your audience. So I would like to share, people are saying it is very, very useful, information is very, very interesting. And
I am glad that it had.
So this is a overall expression coming out of many comments which we are receiving on YouTube as well as here on Zoom. So the first question is, can we measure IL-31 in canine atopic dermatitis, interleukin 31?
So interleukin 31 is a protein secreted by immune cells, and it is very unique that it is responsible for a lot of the itch in atopic dogs. And in other countries, we also have antibodies that will block interleukin 31. Interleukin 31 is produced, we have done some studies that we have not published yet. If we challenge a dog with an allergen, interleukin 31 comes very, very rapidly, but it goes away. And I am not, we can sometimes, you detect it in the skin, but we don't detect it in the blood. So looking at measuring interleukin 31 in the blood will never work. Even if we have lesions induced, and we know that the IL-31 protein is in the skin, we see it, you cannot detect it in the blood. So it might be detectable in the blood with severe lesions, pruritic, but keep in mind also that interleukin 31 is only one of maybe 200 mediators important in atopic dermatitis. It's very important for itch, but it's not the only one for itch. So I don't think there would be any use ever for measuring interleukin 31 as a diagnostic or treatment feature.
Thank you, sir. Thanks for making it clear. The next question is, can we use cyclosporine, ketoconazole, and prednisone at the same time to treat chronic case?
So excellent question. You need to keep in mind that ketoconazole will affect the elimination of cyclosporine. It prevents the liver degradation of cyclosporine. So if you use ketoconazole, you can in fact cut the dose of cyclosporine by 50%. If you use cyclosporine alone at 5 milligrams per kilo, you can use cyclosporine 2.5 milligrams per kilo and ketoconazole 2.5 per kilo. So you have, let's say, an effect on fungi, on Malassezia, but you can also reduce the dose of cyclosporine by using ketoconazole. Here is something I will give you my own opinion. I may be a heretic. This may not be standard dogma. The standard of care is to use a lot of antibacterial and antifungal. I think it's misguided. Because if we recognize that inflammation changes the skin barrier and that the skin barrier change will increase the amount of infection. Yes, we can treat infections, but the answer is to treat inflammation and eliminate inflammation. Do not tolerate a little bit of inflammation. Even if you don't see inflammation, there will be some in the skin that may still affect. Your goal is to treat inflammation completely. Completely. Not any itch, not any redness. And if you do that, your infection will be gone. We have done studies that show that the lipid change, the protein change, and the microbiome changes on the skin of a atopic dog. If the inflammation disappears, they disappear on their own. This barrier defect, lipid barrier defect, protein barrier defect, microbial barrier defect is a secondary change. Nobody has shown it's a primary change. So treat inflammation first and strongly, and your infections will go away. That's my opinion. And we have done some study to show that, but a lot of colleagues will not share this opinion.
Thank you, sir. That was very, a broad answer and clear from all the aspects. Thank you so much. Sir, next question is about TRPV1 inflammatory pathway. So would you have any experience in the role of TRPV1 inflammatory pathway? And can blocking the TRPV1 help?
Are you speaking of T like Tom, TRPV1, TRPV1?
Yeah, TRPV1 protein, it is a protein.
So TRPV1 is a channel on neurons. Every molecule that induces each, not everyone, but most of them will open the TRPV1. The TRPV1 is also affected or opened artificially by using hot pepper compounds, in particular capsaicin. I think it's a little bit too complex a question for this audience. Yes, you can, by using hot pepper extracts, desensitize neurons, kill neurons in the skin. But before you do that, you will induce a lot of inflammation. So it's a little bit too specialized. You can do it, but it's probably not something for general practice.
Thank you, sir. Sir, this is very specific. How we can decide an interval to follow food elimination trial?
So we have actually done some studies on that. You can look online. I'm going to type something here. Just give me a second. I'm going to send you a link through the chat that you can share.
Yes, sir.
So this is a website where you can download so far 9 articles. Oh, just hold on 1 second. Okay, it doesn't allow me to select the website, but just type this in Google and you will find this website. And there are 9 articles on food allergy, and one of them specifically addresses the duration of elimination diets. Okay, this is okay. You have the website here. Feel free to share with your colleagues.
Thank you, sir. We got that message in chat box. Thank you so much.
Yes, yes. You can actually download all of these articles for free.
Thank you, sir. So next question is about a product, Allerderm Spot On, which is by Virbac, and can it help in canine atopic dermatitis? That is a question. So basically, they would like to understand your experience with Alerdum spot on.
So it has been shown to normalize the skin barrier at the site of application. There are studies for that. The issue then is, as I told you, for me, inflammation treatment normalizes the barrier. Why should I just normalize the barrier without treating the inflammation? And second, what the studies from Virbac showed was that it normalizes the barrier at the site of application. But atopic dermatitis is a generalized disease. Even in normal looking skin, if you look microscopically, there is inflammation. There are more inflammatory cells, there are more cytokines, more inflammatory mediators. There is more bacteria, more malassezia than normal. So I have a hard time looking at applying a pipette to normalize the barrier everywhere. You might use it in some problem spots, but I think the answer is to treat inflammation and use fatty acids orally rather than topically, because orally you will normalize everywhere. Topically, you normalize at the site of application. There were other studies that were done applying it at different areas, and the efficacy was not, it didn't have any efficacy to prevent or to treat the skin lesions. But it does the effect at the site.
Thank you, sir. So this is about the dosage of ketoconazole. With ketoconazole, we reduce the dose of cyclosporine by half. What about the dose of ketoconazole? That is a question.
Ketoconazole, 2.5 milligrams per kilo once a day, at the same time as cyclosporine. I'm typing it here in the chat.
Thank you, sir. We got that.
Then reduce the dose of. It's been shown to be equivalent.
Thank you, sir. Next question is, can Montelukast help in treatment of atopic dermatitis?
Excellent question. Montelukast is a leukotriene receptor inhibitor. What I can tell you is that over the last 30 years, about 4 different leukotriene inhibitors have been used in atopic dogs. None have been shown to be effective. So it seems that even though the skin of atopic dogs contains leukotrienes, LTB4 in particular, leukotriene inhibitors have not shown to be effective. So there is no rationale at this stage to use Montelukast for atopic dogs.
Thank you, sir. Next question is, can we combine prednisolone with oclacitinib?
Yes, you can. And in fact, oclacitinib only blocks a few cytokines. What I recommend is you use oclacitinib, but you start with 2-3 days, 4 days of prednisolone. To cyclosporine with oclacitinib will only block the signal of the cytokines. It does not prevent their production. Prednisolone will prevent their production. This is why we have a rebound, because initially oclacitinib blocks the cytokine, but they are produced. So when you reduce the dose of oclacitinib, there are hours during the day in which the cytokines are not blocked. So my recommendation would be start oclacitinib, 2, 3, 4 days of prednisolone, and stop the prednisolone. You will have a much better effect.
Thank you, sir.
And also keep in mind that oclacitinib has no effect on many other mediators that are present in the skin of atopic dogs. Steroids will. So you will have they are much broader in action, and you will have I would say every dog with atopic dermatitis should have a start of treatment of a few days to a couple of weeks with oral prednisone. And then you switch or you add other drugs. But they are the most powerful. Again, short time, as needed to control the signs.
Thank you, sir. The next question is long. I'll read it for you completely. Is the circulating immunoglobulins antibodies are specific to environmental antigens in this type 1 hypersensitivity reaction causing pruritic skin disease? How this atopic dermatitis prevalence in feline and murine species? So there are a few questions basically.
So yes, IgE antibodies are contributing to the capture of allergens and the acute inflammation in the skin. In fact, we tested an antibody against IgE and we were able to prevent the flare of reactions. In my dog model, I only got reactions to house dust mites if the dogs had IgE against house dust mites. So yes, they do. And again, for the cat, what is the question for the cat?
Yeah, how is the prevalence of atopic dermatitis in feline and murines?
And?
Murines.
So in mice, there are multiple models of atopic dermatitis in mice, but in cats, it's also quite prevalent. So the ICADA group is this International Committee of Allergic Dermatitis of Animals. We have written 4 papers on what is called now the feline atopic syndrome. They will be published open access in the journal Veterinary Dermatology before the end of the year. So just wait to get more info. It covers pathogenesis, clinical signs, treatment, definitions. It will be published before December online.
Thank you, sir. It is 9 o'clock already here in India. So Dr. Nagarajan sir, can we take some more questions or we should move ahead?
Yeah, we can finish up with one question, I think. Okay.
Thank you, sir. Thanks for your permission.
And there are only 2 questions, sir. Last 3.
Last question? Okay, fine. So the last question is, if there is a secondary infection to atopic dermatitis, will you advise including antifungal or antibiotics to the treatment? I think this is the simplest, most question.
Yeah, if you have, okay, I will differentiate. If you have red skin alone, the bacteria and the yeast are there, but treat inflammation. If you see pus, pustules, epidermal color reds, or swelling or exudation, you may have an infection that needs treatment. Then do a cytology and treat based on what you see.
Thank you so much, sir. Thanks for your answers. They were very elaborative, clear.
Thank you.
And very, very useful. Thank you so much.
There are 2 questions which I think will be relevant here. People are asking about hypoallergenic diets and whether hypoallergenic diet or an unallergenic diet is good for the regular flow of treatment. I think we'll take that question too.
Thank you, Dr. Prasanna. So from the remaining questions, hypoallergenic diet, how to follow the schedule for hypoallergenic, whether we can quickly shift the animal on hypoallergenic diet after detecting atopic dermatitis.
So there are different types of diet. Some are called hydrolyzed or extensively hydrolyzed. And I don't know, do you have the diet analergenic from Royal Canin?
Yeah, we have.
So this is a very digested diet that is that we have done studies of, and that is really quite remarkable because even dogs allergic to chicken don't react to it. And then you have a lot of diets with different types of protein. I have some concerns about this because I am working right now on, I'll give you an example. I just finished a paper last week. We found 9 allergens in chicken that are recognized by dogs allergic to chicken. These 9 proteins have such a very high sequence identity with the same proteins in beef that if you have this dog allergic to chicken, that you give him a beef containing diet or a rabbit containing diet or a kangaroo containing diet, it's very likely that he will still eat because he's recognizing the same proteins in the beef, in lamb, in any type of mammal protein. So I am starting to think, and I don't have any proof, that maybe the diet should be more vegetarian, which in India I understand would be probably more appropriate because they will be much more different than the meat containing diets. It's a long story. I could talk about it for about an hour, so I probably should stop there.
Okay.
Thank you very much, Dr. Olivry, for that.
Jairam?
Nagaraj sir, I think all panelists will come up.
Yeah. So I would like to thank Dr. Olivry for a very excellent talk. And I would really, AVD thanks Virbac and its team, Dr. Vinayak Surve, Vanessa, for their support. And AVD has taken off in a very big way. And I request everybody to note down the dates of 26th August, where there is Dr. Han Hock Siu speaking, and AVD is supporting that program. It's an evening lecture at 5:30. We will make sure that we will circulate it. And I thank Dr. Prasanna for the back support, without which this program will not be successful. And I, again, AVD would like to thank practitioners from India and across the world for attending. We have had more than 300 people attending on the Zoom channel and more than 200 attending YouTube. That is a great achievement, and congratulations to AVD. Please try and attend the next talk on Saturday. Thank you. Thank you, Nagarajan sir. Thank you.
Thank you very much for having me, and it was a pleasure and excellent questions from the audience.
Thank you,
Good evening to you all.
Thank you, Dr. Olivry. Thank you.